Hey, welcome back to our podcast, Project Brightside, where we always look on the bright side, even when things are looking pretty dark. I'm Dr. Shelby.
And I'm Richard Brito, and we're your hosts for today's episode.
Topics of discussion for our podcast include society and culture, education, and TV and film.
Each episode of Season 2 will have an interview of a guest speaker, followed by a Bright Talk segment where we discuss a complicated topic in hopes of shining light on it.
For today's episode, we'll be interviewing Dr. Nicole Cheung. Hi, Dr. Cheung. Welcome to our show.
How are you doing today?
Thank you for having me. Doing good. It's like the middle of the week, but hanging in there.
Yeah, no, I feel you. But I'm so happy to have you on and to have you as the season finale guest speaker. So thank you so much. So we know you very well. So tell our listeners a little bit about yourself and your interest professionally.
Yeah, hi everyone. So my name is Nicole Cheung. I'm currently an assistant professor for science education, and I primarily teach pharmacology at Zucker School of Medicine. So my background is that I am a clinical pharmacist who specializes in geriatrics. And I do practice in ambulatory care, teaching in pharmacy schools in Florida and Pennsylvania.
Nice, super impressive.
That's awesome. What do you feel like kind of led up to you choosing your career path, or what made you choose it?
Yeah, so I feel like there's like a divide between saying, do you say you're a pharmacist first, or do you say more so primarily an educator first? So I feel like for me, it's kind of like a mix of both because pharmacy primarily was like very important to me because I feel like for everyone, we always want to wish people the best in terms of happiness and health. You know, health is something that's so important that we could provide. And I feel very privileged to be able to be in this career path. And with academia specifically, I feel like it's just like an elevated level on top. You're not only contributing to your community, but also educating and really giving that support and mentorship for the next generation of our healthcare providers and leaders. So again, very grateful to be able to in this path I am today.
Nice, yeah.
Oh,
I,
that's awesome.
I agree. Being in academia, like you're responsible for transferring that wisdom, that knowledge, those experiences that you've gained and helping others, that are going to be going into the field. I did want to ask, so what kind of day-to-day obstacles have you faced and how have you overcome them in that academia world?
Yeah, I like how you mentioned that, Richard, because academia for sure is not for the faint of heart, right? I feel like there have been some studies that show that roughly like less than half of the faculty, primarily like those in like healthcare fields like pharmacy or medicine, really do experience burnout, especially for those who are like on the younger side of their career, like assistant professors or like women who have to balance their work-life career. And burnout is something that's very prevalent because for academia, we don't really have set hours. You know, throughout 24 hours of the day, we're working on either being in the classroom or working with our students for mentorship or being in the practice site, doing research or doing service with our committees and whatnot. So it's a lot of items and you really have to like manage your time very well and to really remember that you have to take good care of yourself so that you're then better able to take care of those around you.
Yeah, totally, 100%. They mentioned in the airplanes like you have to put the mask on first before you could help others. If you pass out, you're not going to be able to help anyone. So, making sure that you're fueled, having like the proper self-care, sleeping right, even though there is no set time and there's a lot of fluctuations. You did a great job explaining that, and you have a lot of good coping skills that you've taught me and you've been there to help me in the past. So I really appreciate you, and you really are a great mentor.
Oh my gosh, no, thank you so much. It kind of reminds me of the time where I have like students who reach out to me in their last year of pharmacy school and they say, "Hey, Dr. Chung, I really need this letter of recommendation. I had like a last minute like epiphany. I really want to do a pharmacy residency. Can you write me this letter of rec in 2 weeks?" And then at that point, you're like, do I put self-care first? You know, you really have to balance it. And certain situations come up where you really do have to prioritize putting the student first and their needs. So
Yeah.
yeah, that's a great example. Mask on first for others, but in some situations you do have to prioritize your students as well.
Yeah, that's a
Yeah,
valid point.
absolutely. No, that makes sense. And yes, you have certainly been an excellent mentor for both Richard and I.
Oh my
So
God,
we
no,
are
thank you so
very grateful
much.
to have you on here. And it definitely is like, well, I'm sure very rewarding, also a little bit of a sacrifice, like you said, because there aren't really set hours and you do wear so many hats. With the challenges that, you brought up, what really drives you to kind of continue in this awesome career and to get you from day to day?
Yeah, awesome career. I feel like initially when I was a pharmacy student, I've never really thought about academia. I was thinking, okay, we're gonna graduate and then we're gonna see patients and we're gonna get a good paying job. So at that point of my career, I was thinking, okay, we have goals. Once we reach that goal, I'm gonna be happy. I'm gonna get what I needed, what I've accomplished after all these years of sacrifice and studying. But I feel like throughout time, after graduating, working at residency in different schools and so forth, midway along my career, I feel like the drive is to really just focus on the present. Instead of finding that next goalpost to feel that satisfaction, what can we find satisfaction today that kind of drives us? So I attended an event last night for the Gold Foundation. I'm not sure if Shelby is familiar with it, but they really work with advocating for humanism in medicine. So
Yeah.
one of the speakers did mention like, oh, if you are to struggle and work with your daily life, one of the quotes is to really love like you're dying. So kind of think about how like, even though you're struggling with your daily lives, kind of take a step back and think about the love you have for your students, coworkers, your patients, or your community. And really just show up day to day. Remember that, people really matter.
Mm,
Yeah, 100%.
that's
And it
beautiful.
it reminds me of it's about the journey, not the destination. And I
Yes.
keep having to remind myself, like, Richard, it's okay. You'll graduate when you graduate. Like, don't try to rush it.
Hmm.
Like, ne next year is when I'm graduating, 2026 for
I was
sure.
gonna say you're like
Summer,
So close to
yay.
summer.
graduating.
But today I had my audit and they were like, "Oh, you've taken all the classes. So like, let's plan now post comp because I take my comps in September and then after that it's like just dissertation." But I was
Mhm.
trying to graduate in summer, and they're like, "Are you going to really be able to do data collection and data analysis and defend all in one summer?" And I'm like, "Okay, so you're
Um,
saying that fall 2026 is my graduation term?" And they're like, "Yeah, be realistic." So it's about like fluctuating between like ideal and realistic, but it's important to stay present and be in the moment because like I'm only going to be a student once, like this is the end of the chapter. I still have like I started I'm going to be a telehealth therapist. I think starting June 23rd is my orientation. But I have to do like the 2 years post MSW, which I never did because I went from my master's to doctorate and stopped that. But now I'm going to try and finish that. So it's a journey. I can't rush through it. I'm going to have so many experiences that I have to like take step by step. And, it's transformative month after month after month. So I really love everything that you're saying. And it does hit close to home. So to reel it in back into 2025, the year that we're in right now. So what are a few of your biggest priorities for 2025?
Yeah, for 2025, I feel like this is one of the bigger years for me because I've
Hmm.
only been in this current role in a medical school for about a year and a half or so. So again, everything's very fresh. I'm just so used to working with pharmacy students and having my practice side versus here now I'm dealing with a different population. They're focusing on step exams, they have different priorities. So I feel like for this year, I really want to kind of build that connection with my medical students, kind of really connect with them on a deeper level, be more involved not only with their didactics within their first 2 years, but really try to see what I can do as a clinical pharmacist for their last 2 years being doing rounds or their clerkships. So one of the ways I'm trying to do that is to wrap up on this research project I'm doing with NEGEA. So I'm sure Shelby could tell us more about that or AAMC. But what they do is that every year they offer us team app collaboration where you kind of reach out to different colleges to work together on a research project. So mine is really to understand what we are doing to really integrate our pharmacotherapeutics between our students within their third years of clerkship, because that's the year where they kind of switch from book brain, the classroom, to be thrown out straight into clinical setting. So what are we doing to really kind of bridge the gap and make sure that the students are well prepared, they know what they can do to promote patient safety and so forth. So again, big goal is to really connect with my students, kind of know what they're doing, what I can do to help, and kind of wrap up on this research project.
Super
That's
beautiful
awesome.
goals. Yeah.
That's really cool. So we talked a little bit about your goals for the next year, and it sounds like some of those will continue into the next 5 years. But do you have any specific things that you hope to aspire or accomplish in the next five?
Yeah, I've always struggled with like creating goals because I'm so satisfied with the present, being open-minded with the future. But
I love
ideally,
that. Sorry to interrupt you, but that's
oh
amazing.
no, I appreciate that. I've always been like, I really love what I'm doing now. Let's just push it forward and keep what I'm doing. But if anything, like you said, I really want to expand on what I'm doing now to really advocate for the role of pharmacists because I feel like I'm in this really unique position as the only pharmacist in the medical school to be working directly with their medical students.
Wow.
So yeah, I really hope to really push for pharmacists in other disciplines to kind of get them involved early on, whether it's in the classroom setting or in the hospital setting or so forth, and really kind of give that representation for medical students to kind of really promote the healthcare we can give.
That's amazing. I love it. So, what advice would you offer to those who wish to pursue a career like yours?
Oh my gosh, for sure. I feel like this kind of ties back to what you said before. It's to really just be like open-minded and flexible because I feel like so in college again, I was doing my clerkships. So for us in pharmacy school, we primarily do that in our last year of pharmacy school. It's that 1 year figure out what you want before you graduate. So at that point, I was really struggling. I was saying, okay, maybe I really do like being in the clinical field and the ambulatory care setting to really work with patients one-on-one. So I want to pursue pharmacy residency training after graduation. So I applied for that, had high hopes. I applied to many programs, spent a lot of money, and I was like very enthusiastic. Round one didn't work out. So I was like, okay, that's okay. It's very competitive. Let's go to round two. Round two didn't work out. Again, if things are matched for you, they would match. It doesn't mean that you're not a good student or you're not competitive enough. So finally, when we have phase three, which we call the scramble, I was really able to find a good fit for me at Mount Sinai, which is a small community hospital on Long Island. And from there, I really learned a lot. So I'll say again, just be open-minded and flexible because there's really no true one route to get to where you need to be.
Yeah, that's awesome advice. And honestly, I'm so grateful with how honest and transparent you are because when I think of you, you're one of the smartest people I know. So like the fact that you like are saying that you didn't match and it's the right time, right place, or having to build upon those experiences and have that perseverance to keep going and get to where, is ideal for you and realistic and feasible. And the fact that you made it happen and you're open about like your process, that is super powerful. So thank you for sharing that, honestly. Not everything goes as planned. We have to definitely embrace whatever's thrown our way. We have to adapt, and that's what you've done. You certainly are a superstar. Like truly, you are phenomenal. So thank you for sharing that.
Oh my gosh, thank you so much. Again, I feel so honored for you to say this because I meet all this like amazing, wonderful people in the field of academia. They're just constantly studying every day and learning every day. And I feel like this imposter syndrome where I'm not where I am supposed to be, but again, kind of take a step back of saying like I'm really happy with the present, what I'm doing so far. Yeah, so thank you so much.
Yeah, yeah, I truly mean it. You're amazing, like truly. So I feel like the smartest people sometimes have that imposter syndrome. It's like, yes, you really are that smart. Like you don't have to compare yourself, but comparison can be healthy as long as it's synergistic.
Yeah, no, I mean, I think that experience that you shared is definitely one that can be applied to a lot of different things, whether, it may be smaller, like the conversation I guess you had didn't go the way you wanted it to. And I think it's great to like reflect on were there things that maybe I could have changed or not. But also, like you said, to understand that sometimes it's just luck of the draw with things
Yeah.
too. Especially with match, like sometimes stuff just happens. And so I think that's a really good perspective and you're a really good role model for, for everyone in general, but particularly for people who, may have dealt with the same thing. I had lots of friends who I think are incredibly intelligent and are in great residency programs that, didn't initially match as well. And so, you know, not to scare anybody that's applying for match in either program. But you're completely right. And you obviously have an excellent career. And so you're a testament to kind of what you're speaking to. For that last question for this section, we wanted to ask you what's one book, TV show, or podcast outside of ours that you think everyone should experience?
Again, highly advocate for this podcast. It's been truly wonderful listening to
Aw.
all these beautiful speakers.
Oh,
Yeah, in terms of like books, I've honestly been really struggling to find that work-life balance to be reading proactively on the daily. But I've been trying to get back into it. Not sponsored, but I don't know if you heard of the app called Libby,
oh yeah, I
Libby.
have. Libby's awesome.
Yeah, Libby's awesome. You kind of borrow like books or like podcasts or like those like reading novels for you guys for free. So I've been trying to like get into that and build a habit because you have to return the books, you have to finish reading before then. But one of the books I highly recommend is this book called No Mud, No Lotus by a
Hmm.
Vietnamese monk called Thich Nhat Hanh. I'm not sure if you've heard of it.
No, I haven't, but it
Oh,
sounds super interesting.
Yeah, so Thich Nhat Hanh is like a monk who was living during the time of the Vietnam War. He saw a lot of suffering from the war, and he's even been exiled for his views protesting against the war, where he had to like move up and everything to live in France and build his own community. And from there, the no mud, no lotus kind of symbolizes that, mud is really the pain, the the suffering, the struggles we kind of have in life. It's just like our day to day, we can't live without suffering. It's just a part of our daily life. And through that mud, that is what really nourishes the lotus to kind of grow. And that kind of symbolizes, the joy, the everyday understanding and blooming. So I really appreciate the book because it really demonstrates that, suffering is a part of life. And instead of trying to get rid of it, really just focus on your present moment. Understand you could live and gain peace through your suffering rather than just escaping from it so you can achieve your own lotus as well.
That's beautiful. That that sounds so great. Honestly, that you're so well spoken, and I
I
love
was
your key
thinking that
message.
too.
Yeah, yeah. Like honestly, like you have really great answers, and I definitely want to check that out. That sounds super beautiful. Like life really is sort of like a roller coaster, and it could have like dirt, or it could have like growth, and it could have like all sorts of things, and you just have to be able to like fluctuate. And some days are bad, and some days are good, and being able to have the adaptation where like if 10, 15 minutes of the day wasn't great, don't let that, transfer for the rest of the day. Really like taking the lessons, taking the experiences, and then learning from it, moving past it. And I think the symbolism that you described is beautiful. And usually White Lotus is like purity and like growth and prosperity. And, when you add mud to it, you're not neglecting that there's like hardships and adverse experiences, traumatic stressful life events, like all sorts of things that we could experience and have to overcome. So thank you for sharing that. I definitely want to read up on that.
Yeah, of course. Thank you for listening. I feel like everyone deals with suffering. So I feel like instead of wishing someone to not have every suffering at all, I just wish you all strength and peace from whatever you have to
Thank you.
experience. Yeah.
Thank you so much. So is a wrap for the interview section. So for our next segment, Bright Talk, where we discuss complicated topics in hopes of shining light on the matter, this week we're going to be discussing ambulatory care and pharmacy practice. So with this in mind, let's start with our questions for the Bright Talk topic. So can you tell us a little bit about collaborative drug therapy management, also known as CDTM?
Yeah, so CDTM, I feel pretty ignorant because I've only learned about CDTM on my last year of pharmacy school, where I had to create an actual protocol and kind of figure out that there is a role for pharmacists. So basically, CDTM is this collaborative practice agreement that pharmacists can have either with like physicians or nurse practitioners. It really depends on the state. And that really allows the pharmacist to kind of practice outside their scope to directly manage the patient's medications. So this can include either starting med, modifying the dose, or monitoring the regimen by kind of ordering labs.
That's awesome. That's really awesome.
That's
Yeah,
very
it's like
cool.
really awesome because I feel like pharmacists can really help a lot and relieve the load because physicians and clinicians can only see so many patients. I feel like with complicated diseases, especially like diabetes or hypertension, where you constantly have to like monitor and adjust the dose. I
Mhm.
feel like pharmacists can really play a role. But surprisingly, the CDTM is not like a permanent law. So for New York State, it's like under like a sunset provision where this policy kind of expires in 2026. So hopefully we'll get renewal to further enable CDTM to be practiced and have pharmacists further help with healthcare.
Yeah, that sounds awesome because that sounds like it's bridging a gap because there's a lot of like treatment adherence like not actually like following through and that impacts therapy, the management of it. So the therapeutic aspect of it of actually like solving what it's supposed to solve or treating what it's supposed to treat, and pharmacists really are like a way to fill in that gap because as you mentioned like there's lack of knowing how to manage it, or sometimes physicians can't explain everything all like during the session, or sometimes people have questions and who do they go to? They might go to their pharmacist when they're picking up their medications. They ask questions there too. So expanding that and having more accessibility through a collaborative environment. That's amazing. That's phenomenal. And I really hope it gets renewed. In it's in New York, so hopefully, it's gonna go well.
Yeah, thank you. I believe most of the states have CDTM, except for
Oh,
maybe like
amazing.
five or so. Yeah, exactly. But again, some may be permanent, some may be just physicians, some may also include nurse practitioners. So every state
Amazing.
has its own laws. Yeah.
Yeah.
And I know that this may vary depending on which state you're in, but having a pharmacy licensure, how can individuals be involved with CDTM?
Yeah, great question. So it's not like you have a pharmacy license, you're fresh out of school. This automatically allows you to kind of have this privilege to sign up with a collaborative agreement to start adjusting doses right away, right? You really need a certain amount of like trust with the practitioner and have the experiences and clinical skill sets to engage in CDTM practices. So I'm not sure about other states, but for New York specifically, I believe you do have to be licensed for at least like 2 years as a pharmacist. You need to have at least a year of clinical experience, and that has to be vetted by someone who really strongly advertises for your expertise. And you also have to be either board certified in something or you've already completed a residency program. So again, unlike medical school where residency programs are required, for pharmacy school, residency is an option.
Wow. No, this is really great stuff to know. And honestly, pharmacists play such a crucial role. It reminds me of like public health. Like we should really have this integration and multidisciplinary collaboration between physicians, pharmacists, public health professionals, social workers. Like all of this is so essential. And I love like being able to collaborate with other professionals and what you're describing, like you obviously need the two. It reminds me also of like therapy. Like I need 2 years post experience after my master's so that I could be licensed to practice independently. So,
Mhm.
and it varies per states too. Like some might require more, but this is all phenomenal. And I really like would love to advocate for this to be pushed forward more in a permanent aspect because public health, pharmacy, medicine, like it's all integrated and there are ways that we could learn from each other and aid each other in a synergistic manner. So thank you so much for sharing this. So I do want to ask, tell me about the process. So like, how can pharmacists directly change medications or perhaps do a ambulatory care residency training? Like, how do people decide, once they have that licensure, what to do next?
Yeah, so for the first question, whether pharmacists can prescribe, I've actually heard like two schools of theory from the people I work with. The first is that no, pharmacists can't prescribe medications. They're legally not supposed to have like a writing pad to write prescriptions out.
Hmm.
But the second theory is that, pharmacists technically do prescribe because when your patients see you at your community pharmacy like CVS or Walgreens, they'll ask the pharmacist, what do you recommend for these symptoms? And you do get a recommendation of what to use, how long to use it, when to reach out to a clinician. So for the over-the-counter aspect, pharmacists technically are prescribing in a sense by giving those
Yeah.
recommendations. But yeah, in terms of like giving like medication adjustments, so as mentioned, like for CDTM, there's really like different protocols, and you really have to receive like a backing from your institution's medical or pharmacy director. So that agreement could either focus on a certain disease state. So it could be either on like diabetes or hypertension, or it can even cover things like anticoagulants or asthma. So it'd be like really specific what disease states you manage, what drugs you can or cannot prescribe. If you're doing insulin, what is that dosing regimen you can titrate, and what conditions, like let's say like an A1C greater than 10% that's not controlled, what situations we reach out to a clinician. So under all that protocol, that's when a pharmacist can then kind of implement changes directly with the medications, again, with the clear written consent from the patient.
Yeah, wonderful stuff. Thank you so much for clarification on that. Honestly, I think it was Dr. Shelby too that mentioned that you have a pharmacist on your team and you ask a lot of questions because it's really great resource.
Oh yeah, our we're actually trying to get one for clinic, but for my inpatient service, yeah, all the time I text them all the time too.
I
I'm
love that. Yeah.
hey, like another question. They're so helpful and they have such a fund of knowledge. So no, I think this the CDTM sounds super cool as well and definitely something that I'll be investigating.
That's awesome.
So, we talked a little bit about some of the roles that, pharmacists play in providing care for patients. I know another big one rather, that's very important is dealing with polypharmacy. Could you tell us a little bit about your experience of working with older adults who may be dealing with polypharmacy needs?
Yeah, thank you, Shelby, for the segue. And I definitely do appreciate using the term older adults. Um, I feel like sometimes people use that term interchangeably with geriatrics or the elderly, and those terms tend to be kind of stigmatizing. They
Hmm.
have like a negative connotation of like vulnerable aged population who couldn't really take care of themselves. So we really prefer in the medical field to use older adults to describe these patients. And in terms of polypharmacy, so in case your audience doesn't know, the definition's pretty like unclear. Basically, some say you're on either like three or more, or five or more, or seven or more medications. But I feel like the true definition of polypharmacy is just that you're overall on too many medications where you're not really sure if you're taking them appropriately, and they can potentially contribute to any drug interactions or side effects, or can overall increase that anticholinergic burden, which kind of increases the risk of falls or confusion that are really high risk for our older adult population. So in terms of working with the older adults with polypharmacy needs, um, I think about this one patient I was working with back at the resident run clinic at Thomas Jefferson. So we had an older gentleman. He has a really complicated history of diabetes, chronic kidney disease, and he's already received like kidney transplant before. Ted lives by himself, has a myriad of comorbidities, and he really can't manage all the medications. It was like at least 15 or 20 medications.
Wow.
So initially we thought, oh, let's get everything organized. We're gonna do mail order, just follow the instructions and take it, right? But again, with these complicated patients, they're seeing so many clinicians and professionals where eventually there's so many changes to the medications we can't really keep track. So when the patient came in, he kind of go through the mail order medications and was saying, oh, I'm not taking that. Oh, no, this has been changed from like 3 times a day to twice a day. So it's just like a lot going on. He doesn't even know what he is or not supposed to take. So the role of the pharmacist working with the clinician and the medical team is to really kind of integrate that care by reaching out to different specialists to see, well, what is the correct regimen recommended for the patient? What are we monitoring for as a primary care team? Kind of review all the medications with everyone, make sure on the same board so that we're then able to reach out to that mail order pharmacy, give them those revisions, and the patient gets directly the medication he needs and with clear instructions.
Wow. Yeah, no, that sounds so complex. But I'm glad that there's a system and there are people like you that are helping people, older adults that are experiencing, having to have 15 plus medications. That could be very overwhelming. That could be, so many different conditions and not knowing what's for what. Like, some, having that educational component of, why you need to take it at a certain time. What are the specific side effects? How could drugs interact with each other? What are some things that you can't have in your diet because it interacts like some people might not be able to have grape juice if you're drinking taking certain medications. So it just depends on like all a bunch of factors and having to map it out and paint the picture or management of healthcare better for individual aspects like targeted interventions of psychoeducation and regarding the medications and whatnot. Like it is all so complex, but it needs to be tackled because that could make such a difference and it could improve the quality of life and it could also make, older adults be able to have the life that, we're all entitled to have and that involves like having health, peace, happiness, and being able to have a supportive system to navigate that, I think is crucial. So thank you.
Mhm.
Honestly, this is like your role and what you do is so important, and I appreciate you sharing with us like all of this because it could inspire and it will inspire people to do, similar steps to you. So
Absolutely. If it's okay, I was just going to add that also addressing polypharmacy can be like a safety issue as well, right, for patients. And so I think, it absolutely is, optimizing and trying to target things and get rid of like a redundant pill burden. But
yeah,
it absolutely is a safety concern as well at times. And so super important. And I just think about people with chronic conditions, how sometimes that can kind of chip away at the reserve of energy that you have to deal with figuring out all these different prescriptions. And so a lot of
yeah.
times it's in people that are already, kind of having to manage a lot or have a lot on their plate daily. So super important. Thank you for the work that you do, Dr. Chung.
Yeah,
Oh
yeah.
gosh, no. Thank you, Richard and Shelby. I mean, like you mentioned, because these patients are on so many medications, like you mentioned, we really focus on deprescribing to lower that pill burden. I always say less pills in your stomach, more room for you to eat, right? So I always want to advocate for deprescribing, but that also brings up challenges with patients who say, "Oh, why are you taking off my statin for my cholesterol, or why are you taking off my aspirin for
Hmm.
protection?" It's like, are you giving up on me? Like, why are you taking all these medications I've been taking all my life? So even though we're trying to do our job of taking meds off to relieve the burden, it can also be very hard to kind of convince patients at certain times of why we're doing it and how to do it safely.
Yeah, and especially like having to do consistent labs to see like the effects that it's doing on your on people's organs, and sometimes that might require like having to wean off a medication or remove a medication because and having to explain that and have that be understood and accepted, because sometimes denial could be at the forefront, and then there's negation of like having to do treatment adherence as being suggested or recommended. So thank you, thank you. So I do want to follow up with a question that I asked earlier, but it ties into this one as well, so we could bring it up. So how do pharmacists enter ambulatory care residency? Like, how does that look like, that process?
Yeah, beautiful. Thank you for reminding me. So again, residency training is really optional for pharmacists. Fresh out their 6 to 8 year PharmD program, you're really well prepared to practice wherever you go in the hospital or community setting. But residency training is like an optional choice if you want to specialize and get that experience of different rotations within your clinical expertise. So when you apply for residency, the first year is always going to be general. So they're going to cover the basic foundations for either inpatient or outpatient setting. And then once you complete your first year, you kind of match to your program with the specialty of choice. So one of those could include ambulatory care residency training. So again, for that 1 year, you could really practice in various settings. You could practice in the VA, the Veteran Affairs, where they have their own scope of practice agreements. They're kind of similar to CDTM, but you could have more flexibility with your scope of practice as a pharmacist with the initiation or modification medications. You can also do AMCAR residency for Indian Health Services, the IHS, if you work with like underserved populations and really want to invest in the creativity to address certain challenges in resource limited situations and outpatient clinics or so forth. So I feel like PGY2s and AMCAR are really helpful to build very versatile and flexible pharmacists who have this cultural adaptability and awareness to deal with very different situations and settings.
Yeah, awesome, awesome. Thank you so much for elaborating on that. So we did work on the Jeezy is in labor scene together for our Morally Gray show. So tell us what other experiences you would like to see on the show and that you think would be very beneficial for viewers.
Yes, thank you for mentioning it. That collaboration was like a lot of fun.
Yeah.
As mentioned, the GZ is in labor scene, I believe is it talking about like a pregnant woman who
Hmm.
was presented to the hospital with like severe pain and she has like comorbidities and she needed to undergo like emergency C-section. There's a lot of confusion, not a lot of clear communication. And I feel like it really ties into what we really need for our viewers, which is really the advocacy for women's health. So that could be including research, or really having more involvement of pharmacists in addressing maternity health. So for instance, I'm sure you're aware that in terms of research, I feel like there are some studies that show that the amount of money we put in research for erectile dysfunction vastly
Yep.
outweighs what we have for like premenopausal syndrome, those symptoms that really cause the primary reason why school aged children are not able to go to school. So these kind of things are how the fact that morbidity from pregnancy is actually increasing through the past years and how like social determinants of health and disparities really significant proportions of that. It's really ridiculous in our current age that we don't have this advocacy for having enough money and funding or laws to really protect women's health. So I feel like we really need more discussions on how we can learn from it and kind of advocate for this.
Yeah, 100%. According to Harvard, in the US, more than 80% of pregnancy-related deaths are preventable. Yet the nation has had the highest maternal mortality rate among high-income countries for many years. So a recent study showed that the rate continued to rise between 2018 and 2022. And there were large disparities by state, race, and ethnicity. So, a team of researchers at the National Institute of Health, in collaboration with Rose Molina of Harvard Medical School, used data from the CDC to study pregnancy-related deaths in the 4-year period. And when they were asked why the U.S. has a higher rate of pregnancy-related deaths compared to other high-income countries, so Rose said, there are many reasons. Our patchwork healthcare system, inequitable policies, maternity care deserts, as well as persistent systems of bias and discrimination across racial and ethnic groups. So she said, while I'm saddened that the racial inequities have persisted, the reality is that this has been demonstrated over and over again in the literature. There have been some innovations aimed at reducing inequities between racial groups and health systems, but at a population level, as a country, we're not seeing meaningful improvement yet. So Rose said, looking forward to the future, she explains that the U.S. can lower maternal mortality rates. So the biggest take-home message is that we need to continue to invest in public health infrastructure. In particular, we need to increase investments in innovative solutions to address quality of care during pregnancy and the extended postpartum period. A lot of mothers are neglected in the postpartum period, and also like during pregnancy, that needs to be pushed forward more. Prenatal care, making sure that there's care all around from start to finish and past the finish line too, because it doesn't end. Motherhood just started. So thank you for bringing that up, and it reminded me of that, and I wanted to share it. So yeah, we're in the United States, and this is supposed to be a really progressive country, and we're falling behind. There needs to be a push for innovation, a push for collaboration, multidisciplinary work, integrated work. Definitely a lot more funding for reoccurring issues, and not have it be so much so like a cash grab. Not saying that, we don't partake in that, but a lot of America does. So we want to definitely transform that. So just my little take. Wanted to bring that up.
Yeah, thank you for sharing. And I feel like especially for pharmacists, we could really play a role with that monitoring phase
Yeah.
because
Hmm.
I believe like postpartum during pregnancy, one of the key causes for that morbidity and mortality is that elevated risk of stroke due to that increased blood
Yeah.
volume and the hormones causing patients to be more hypercoagulable.
Mhm.
So during that sensitive state, I feel like pharmacists can really play a role in terms of following up with patients, using telehealth to reach out to these healthcare deserts to assess blood pressure monitoring and how we could prevent these deaths going forward.
Yeah. Yeah. Great solutions. I definitely see that.
That was a great conversation as well. And I mean, going into the, you know, maternal morbidity and mortality is an important conversation and one that deserves a whole nother
Yeah.
session as well for sure. So I'll save my comments, but I certainly agree with what you all have said, and certainly the disparities that we've seen in our country. So on that note, thank you so much again, Dr. Chung, for coming out. It's been such a pleasure to not only catch up with you, but also to kind of hear your inspirational words and your advice and hear all of the new exciting things that you're working on. So this has been a wonderful conversation, and that is it for episode 12 of season 2 of Project Brightside.
Woo! Thank you for tuning in and supporting us. Make sure to recommend our podcast to your friends and family, and make sure to keep sharing. So that is it. That is a wrap for season 2. We appreciate all the love our listeners have given us for season 1 and 2. We will be taking a little break to plan for season 3. So until next time, take care.
Episode 12 of season 2 of Project Brightside was executive produced by Richard Brito, Lou Curiosity, Shelby Floor, John Scrivenich, Jake Curiosity, Sophia Paez, Andres Gil Arana, and Zoe Rushetsky. Music by Jake Curiosity. Edited by Lou Curiosity and Richard Brito. Research by our research associate, Margaret Lee. And a special thanks, of course, to Dr. Nicole Cheung.
Thank you so much. It was so much fun having you, and it was really nice catching up.